Okay, so we are going to do pharmacology. This may hematology. Mm, we're gonna see what hematinics is. Hematinics, basically iron or B12 or like um folate. Hematinics is something that helps in the formation of blood. So these three obviously help in small amounts, copper and pyridoxine also. I think it's B6. Uh, so yeah. They're all required for the formation of blood. So we can see about iron, which is like daily requirement for iron. For male it's 1 mg for male. For female it has to be more because you know they lose blood during menstruation, during uh, and also they have a little they have like pregnancy and all, they need more blood. And in pregnant female also, like 3 to 5 mg pregnant female. Now what are the sources of iron? So liver like meat, eggs, yolk is also a good source of iron. And then bean, and then dry fruits, and then milk and all, they're all good products. So iron is absorbed mostly in the duodenum. Okay, so this is your stomach. So iron is basically in the duodenum, absorbed here, and in a ferrous form, which is like the lower oxidation form of it. Anything that has us in it after is the lowest, its lowest oxidation state. So ferrous is +2. It comes in two forms, +3 and +2. So +2, it's absorbed in ferrous form, and heme contains the iron in ferrous form, and most of the inorganic iron, which is in ferric form. This is ferric form. It's still organic. Uh, is an inorganic iron. Now this must be reduced to ferrous form for absorption, thus reducing substances like ascorbic acid. So we have seen that with vitamin C, we have read that vitamin C helps in the iron absorption. So vitamin C actually helps in the reduction of ferric to ferrous form. Uh, ferrous form. So that is how it helps in the absorption. Also HCl helps in the reduction, and it increases the absorption. On the other hand, like the opposite, like the alkalis, the phosphates, the phytates also. Phytate. Phytates actually they're antagonists to vitamin C. Phytates and tetracycline. You can remember this one, tetracycline. They decrease the absorption. So vitamin C and HCl they increase the absorption, and alkali phosphate, phytates, and tetracycline they actually decrease their absorption. And after absorption, iron can either be stored as ferritin, ferritin is a storage form, or it is transported with transferritin to be utilized in the formation of blood. Where there is excess of iron in the body, when there is excess of iron, the ferritin is a storage form. The ferritin is a storage form, excess iron here, so it will combine with apoferritin to form ferritin, which remains stored in a mucosal cells and is removed by the body when these cells are shed. So in case of like iron deficiency, number of transferrin receptor increase because which is known as like TIBC, transferrin iron binding capacity. So transferrin receptor increase in iron deficiency. So on the erythropoietic cells, so iron selectively goes to these cells, resulting in brisk um, erythropoiesis. Now, iron is used for prophylaxis and treatment of the iron deficiency anemia, which is microcytic and hypochromic. Both, like the size is also less, and the color, uh, because of the because of the hemoglobin, the color appears, the color given to the RBCs because of the HB. So if HB is low, the color will be low, so hypochromic. So it can be given IM, this IMIV, which is a parenteral route. They can also be given an oral route, and it is indicated when oral iron is not tolerated or absorbed or along with erythropoietin. When we are giving erythropoietin, it has to be given parenterally. So if we are giving iron with it, तो हम parenterally देंगे. Otherwise we can give orally also. But and also if orally iron is not well tolerated, then we can give parenterally. And rate of the hematopoietic response with the parenteral iron is not faster than that with the optimal doses. So oral is not a problem. Now oral preparations are there, including ferrous sulfate. This is the ferrous sulfate oral preparations. Oral preparations are there with ferrous sulfate and gluconate. And gluconate are there, and succinate are there. So these are oral preparations for iron. Ferrous sulfate, it contains 20% of elemental iron, like ferrous form. Elemental iron is 20%. And for the treatment of iron deficiency, the dosage recommended is 200 mg. 200 mg of the elemental iron daily, that can be obtained by giving 1000 mg, sorry, 1000 mg of ferrous sulfate. So like it's 20% of the ferrous. Let's just see what is 20% of this thing, which is 100. But, but still we give like 1000 mg ferrous. But in three divided doses we give, so providing around 60 mg elemental iron per dose. And iron absorption increases in response to low iron stores. So increased iron requirements, the reticulocyte count also increases in 2 weeks. If like you have iron deficiency, if iron deficiency is there, the reticulocytes is low, right? And reticulocytes uh, become low in comparison to the decreased iron in the body. So there's a feedback mechanism which allows the reticulocyte to increase in numbers. So a reticulocyte begin to increase in 2 weeks. So in the second week, it starts increasing, and in the fourth week, it reaches its peak. Okay, this suggests that it was a good response treatment. We can check on second week, we can see the reticulocytes are increasing, and we can then check again on fourth week. We can see the rises on peak. So that's a good response treatment. And treatment with oral iron should continue for like 3 to 6 months. treatment should go on for 3 to 6 months. And this will correct the anemia and replenish the iron stores. Now, now what I wanted to do is tell you how much hemoglobin level rises. So rise of the hemoglobin is zero point 0.5 to 1 mg, 1 gram per dl per week. So this much iron per week and this much hemoglobin per week is increased. So and the treatment goes for like 3 to 6 months, right? And if there is adequate response to the iron therapy and prophylaxis of the iron deficiency, like 200 mg ferrous sulfate once daily is enough. Okay. And in pregnancy, iron should be started in the second trimester. If somebody is pregnant, like female is pregnant, then in the second trimester, uh, we start the iron therapy. And major adverse effects of the oral iron that can result gas gastrointestinal problems are there. Then there are epigastric pain, nausea, vomiting, and metallic taste is there obviously. Metallic taste. Another example of metallic taste is because of the metronidazole, and these are because of these GI nausea, vomiting, and the metallic taste. These are because of the elemental iron in the preparation. Now, this also like we have ferrous sulfate. This ferrous sulfate ka preparation is there. We also have ferric citrate or ferric citrate, ferric citrate, and it has the capacity to bind phosphate and form non-absorbable complex. So it is indicated to control hyperphosphatemia. So we all know that phosphate decreases the iron absorption because of binding of phosphate to the iron. But in case of phosphate poisoning or excess phosphate or hypophosphatemia, ferrous citrate can be given, and it will f- uh, it will decrease hyperphosphatemia. And in the patient with chronic kidney disease, like CKD is there, dialysis is going on, cannot be like kidney cannot function properly. In CKD patient, we give ferrous citrate, and it is given orally also. Can be given orally. This parenteral iron preparation, so these were that was the oral one, gluconate, succinate, and ferrous. We have parenteral preparation, which is iron dextrate. So iron dextrate is there, dextran, and iron sorbitol citrate. So iron sorbitol citrate.